Or I believe we are live now. Welcome to UMACO TV. My name is Kemal Erkan. Today, our guest is State Representative Paul Baumbach. Representative, how are you doing?
I'm doing very well.
So thank you for being part of the show. And I don't know if you were able to watch any of the prior ones, but what we do here is almost every Friday, we have different type of either guests or updates from healthcare, U.S. economy, and global issues. United Medical is one of the accountable care organizations, and also we are a healthcare service provider. From the vendor standpoint, we have, as you may know already, we provide revenue cycle management services. The old name is the medical billing. We provide EMR software and then practice management software. And then we became the ACO, the Accountable Care Organization, since 2016. We are one of the 4 ACOs in the state of Delaware. What makes us unique a little bit is we are the only homegrown private ACO. So 2 of them are hospital-based. The other one is nationwide, and they're not from Delaware. So with that, our quality and our overall cost actually is extremely competitive, and we may be one of the lowest in terms of the cost. And quality-wise, we are one of the best ones out there. Now, what I do with these, and Sean, who's actually in the same room with me, and he'll join us maybe later, we host the event, and in some cases, just like yourself, we have other state representatives or the senators, state officials. They come and we ask them questions related to either maybe the current topic that they may have, or we may need some help in the healthcare area. So now, recently, CMS, as you may know, they proposed changes on standardized electronic healthcare attachments, transactions, and electronic signatures process to improve the patient experience and the for patients and the providers. So this is also bringing the prior authorization. So then we look at the prior authorization history in the state of Delaware, and your bill that you sponsored, I believe, 7 years ago. And I wanted to actually ask you some questions, but I want to let you first explain, maybe give us the background of what that bill was, and then I can ask my questions after that.
That sounds wonderful. So in 2015, and I was just in my 3rd year, the bill came to me, and I use that phrase very deliberately. Legislators are often masters of jack of all trades, masters of none. And I say that I'm on the health committee, but it's not because I have a health background, but rather I've watched a lot of Grey's Anatomy episodes. So I rely on the community, the medical community, to reach out and share concerns and share solutions. So in 2015, medical community came to me and said, we are trailing many of our neighboring states, and we need to catch up, if not jump ahead, in the area of prior authorization. So in a very limited number of months, we had a bill together, and we got it through the committees and the chambers and turned it into law. And it was at the time to have Delaware, get to the front of the pack there. Well, it's been 8 years or close to it now. So it's time to look at this again. And, both United and also some of the other organizations, the Hospital Association, the Medical Society of Delaware, are all raising the alarm that it is past due. And as you point out, CMS is also very active in this area. And oftentimes CMS sets a minimum level, and then the states will supplement and grow beyond that. This may be the case where CMS is doing a little bit of leapfrogging themselves and getting ahead of some of the leading states, which is fine. But the main challenge at this point is we've got a moving target. So we've got what the other states are currently, and that's static. And then we've got this CMS that may be jumping ahead, and we need to figure out how do we get up to the top states, and if we need to, up on top of where CMS is requiring it. So it's very much a moving target, and we do not have pen on paper with what we'll be proposing, but we do know that what we're looking for is a quicker turnaround time, a longer period of time that the authorizations are valid for, and a greater attention to the data, what we do with it. So it's not just that it goes into some bucket never to be seen again, but rather we have that data in there, we can report on it and learn some lessons and maybe make some adjustments beyond that when we have that data in hand.
Now, because of what I do day to day, I'm going to actually give you some maybe examples of the real life stories. And I didn't mention earlier, but I also other than providing services for our physicians, it's about maybe 160, 170 with the specialties altogether in Delaware, but we do have clients outside of Delaware in about 29 different states. But our ACO business is mainly focused in Delaware. About 115,000 patients at the primary care level that we provide services. Now, I do own one of the primary care offices. So although most of them we are providing service as a vendor, but I also do have a practice that it's owned by us. With that, we also have a surgery center, American Surgery Center on Folk Road. I'm the managing partner for our surgery center. Now, just to kind of give you day-to-day what we have to do for the authorization, and I'm going to apologize in advance so that we don't know each other. So, and if I didn't actually know about you until last 2 weeks ago, maybe, and that's probably my bad. But when I heard about the prior authorization bill, I'm like, what was it doing and how it was helping us? That was the first thing that came to my mind. Then I said, well, you know what? Let's have a discussion and then see if we can actually maybe help them to better understand. So I'm going to give you some examples. So in the surgery center, we do bariatric cases and general surgery cases. So average authorization is about 2 weeks. It can go up to 3 weeks in some cases, but 2 weeks is pretty standard. Now, the bigger problem, which I may need your help with this, maybe knowing this would help. It's one thing that we have a very good business database that helps us to keep track of when we send certain things, what needs to be sent, which insurance wants what documents. And I don't know how some of the smaller offices are doing. However, we then still have to wait for that time. But then after we get it, if the patient is no longer, if let's say Medicaid or one of the commercial one, if their insurance changes, but it's not reflected, so we get the authorization, but then now you have a patient with no insurance. And then although you do have the authorization for that insurance, they say that's not guaranteeing the payment. Then we get a denial, and then they ask for medical documents again. Or they say there's a system denial. Like we just had a meeting with one of the Medicaid MCOs yesterday. Then I said, look, you're denying this. We already had the authorization. Patient is your patient. What would be the reason? Who's actually putting this denial on something that has a very intensive way of getting the authorization? And they have no answer. So that's something that we see from a specialist standpoint, like surgery center side. And I do want to give you the perspective of the primary care. So one of our, on the United Medical Clinic side, primary care side, one of our issues is answering our patient phone calls in a timely manner. And it's tough, it's difficult. And sometimes calls are not coming evenly distributed. They're coming at the same time, and then you don't hear anything for an hour. But then of course, we have this same database, and then we start registering each call. And we get these referral requests, either sometimes from the patient or from the specialist, or authorization requests that we haven't seen the patient. So it's almost like using us as like just like a formality, like I need to get authorization, but then I haven't seen, we didn't send you to a specialist. So if you need authorization, we would initiate that anyway, right? So those two are from the PCP side, primary care side, and from the specialist, very common. I don't know if you had that background on the actual day-to-day issues and the bill that you have in place. Do you think that actually satisfies the need that we have today?
So I'm going to go to the easier question, which is the last one, which is, I think the answer is no. I think that what we did in 2015 probably got, if I were to give it a grade, like it was in school, I'd give it a 90% for what was needed in 2015. But we're not in 2015 anymore. And the legislative process is one where you're listening to all the stakeholders and including those that you're making things tougher on. And you got to get them to not be screaming at the top of their lungs, this is terrible. So you give in here and there. And so that we made the trade-offs to reach a consensus that we could in 2015. Well, again, we're several years beyond that now. And the timelines, the turnarounds that were reasonable in 2015, with technology having advanced during the past, almost 8 years, I think those turnarounds can absolutely and should absolutely be shrunk. So I think that's a key issue that we need to be focusing on. The issue of getting the referral confirmations from places that sort of have no reason to be doing that to you. I'm not sure that's something that legislation of this nature can address. It's not to say that there may be a legislative solution to that, but I think that's sort of adjacent and not what I would say a focused prior authorization issue. When a patient shifts from one piece of coverage to another piece of coverage, I think just the nature is that even though they got approved before, if it's a different provider, a different type of policy with different rules, it's completely, I think it's understandable that a fresh prior authorization process has to happen. But hopefully with new law, we can get a faster turnaround dependable.
So I want to actually elaborate a little bit. It's not the way that when we check the eligibility, patient still shows, let's just use an example, Mary Health Caritas. So patient insurance on the portal, it says Mary Health Caritas. We get the authorization. On the day of the surgery, we still see the patient with Mary Health Caritas or health options. So then I'm not picking on one of them, and then both of them have similar problems. So then information is updated. As you know, sometimes with these MCOs and the Medicaid, the communication happens in two different portals. What may be available to us from the insurance portal may not be what state has in the Medicaid portal. DMAP, I believe it's called. So then that's updated next month. So next month, they retroactively change the effective date of the patient's coverage. And then it's already too late. So we are left with no, and like what you are going to ask me, like, how do you actually get paid? We have to fight. It's like the Ukraine-Russia war. It's like we have to fight. And we are kind of in the Ukraine position. The other side is stronger. So from the primary care side or from the specialist side. So we are not at the same level. So when they don't pay, the service is already provided. It's too late. So that's why this prior authorization actually is not just important from the process and how we get it and how quickly we get it, but what it does for the later on transaction that we have. And there's a lot of shortcoming of the existing system. If you are, since you are one of the main sponsors of the bill, and I'm assuming that now you have more interest in healthcare because we have another topic that we are going to talk about. What I was going to suggest is maybe something we can have a meeting with maybe a couple of our providers and with you and explaining just for you to see the real problems that we have on the authorization side and the processing these issues that we have with the payments related to the authorization. So we can, follow up. We can have a follow-up meeting if you would like.
So if I can dig into this a little bit. So I know that I've heard just in the past few weeks that in the past few months, there was some handoff from one Medicaid carrier to another by the state over the past year or two. Is that accurate?
Delaware First, are you talking about the new one, the new MCO? Delaware First.
It sounds like there was a handoff without the person's knowledge that they're being handed off from one to another. And I literally have just heard about that in the past few weeks. But what I'm hearing you say is that there is not currently a reliable clearinghouse where you can go to and confirm that the patient who's in your office has the insurance that matches the card they have, that may have changed, and you may not get that confirmed for a month out after the service is delivered. Is that what you're speaking of?
That's absolutely exactly how that is. And because they are not in the same clearinghouse, I call database, but
sure.
State Medicaid is using the system portal name is DMAP. I guess Delaware Medicaid something, right? So DMAP.
Yep.
The other one, MaryHealth and Health Option right now, they go through Nevinet. Nevinet is a nationwide vendor. So like even for Highmark, Blue Cross, Aetna, and other insurances, they're all, most of them are through Nevinet. It's one of the big ones. But that information is not identical what state may have because that communication happens in two different domains. So, and then those domains are not owned by same organizations. One is the state, the other one is the private company. So then when they then reconcile the differences later on, then all those goes effectively retro to the day of whatever they discover. So, this is, other than Medicaid, since you are interested in this also happens with the commercial insurances. So what we have to do, what I tell my practices, get a screenshot and then save that to the patient's chart, because what happens, then they don't believe you. Like if you don't have that proof, so they're not coming out and saying that we did change this retroactively, so that information is not available anymore once it's out there. So then all of a sudden, boom, you have this, like you feel like kind of like stupid. It's like, oh, well, I did check it, but then if you don't have the screenshot, you didn't check it. So,
yes.
And that's a burden, right? So that's another way, step that our offices have to do. So like every time when the insurances or anyone who's in the healthcare, they don't listen to the problem that we have, I offer them to spend 4 hours in the call center. So just 4 hours. And then it's, what's happening in real life is really different than what we think it's happening. So patients are demanding, insurances are demanding, other organizations who may need information from us, especially the way that PCPs are being treated is pretty bad. It's just like if we have to stamp something for specialists or for the hospital or for the nursing home or for the home health. Well, we are the primary care, so we are the center of this patient's core responsible practice or provider, and then they're like, oh, we need this, we need that. Well, no, you don't. Let me see my patient first, right? So we can actually engage the patient if they need X, Y, Z. But those are all different issues that we are having. But I will definitely give you actual examples. Now, one of the other things that I train my people in our central business office, we have about 120 employees on the business side. We actually put a complaint to the insurance commissioner. And in some cases, even for Medicaid, we do, although that's not it's not in their jurisdiction, they still ask us to do it so that they can communicate. And guess what happens? So insurances are just so upset when we do that, because every year they can be fined up to a certain level. And and then those are public numbers. And I know that when there are more than, I think we probably increased that number because not many provider offices know to do that.
Yes.
So, because we are doing that, I can actually show you so many different examples that we have. Just yesterday, I had one of the meetings with one of the Medicaid MCOs, and there's no answer. And then I can't really be upset with the individual because they're not being given the authority, but they're on the call with us. And they're like, why are we having this issue? Like, you should be, like, you got the prior authorization, patient has your insurance, why are you denying it? Not just not paying it in a timely manner, but they're not even, they're denying it for authorization or for this. So there's so much glitch in the system, so much disconnect, perhaps. And in some ways, it's discouraging because I can tell you, and I'm not going to be humble about this. Usually I try to be humble, but for private practices in state of Delaware, one of the reasons there's still private practices because of me, because I put this central office support for my clients and for my own practice. And because of that, we are changing the way these practices are functioning these days. Although they have different ownership, we still have one approach when it comes to patient care. And when we deal with the insurances, and it goes through the central business office. And that's something that insurances also don't like, because now there is a almost kind of an equal counterpart. So every day we have these difficulties. And when I heard about, you personally being interested in this prior authorization one, I definitely would like to meet with you, with my team, and then we can hopefully help our private practices in Delaware.
And what I find from working on contentious issues in the past is I have to sort of size up what the issue is. And we have the phrase of the Hatfield-McCoys, which is a story from, I think, the 1800s, of two families that couldn't stand each other. And I think it's from West Virginia. And you never want to put them in the same room because fists are going to fly. Okay. So I want to find out who the parties are, and I want to see the level of contention. If possible, I'd like to get them all in one room. And I'd like to do that so no one can point fingers at someone who's not there. And that way we can say, look, the problem is in this room, but so is the solution. Let's find that solution. However, if it's a Hatfield-McCoys and folks they will not constructively work together, then we do what I call shuttle diplomacy. And I'll sit down with one group, and I'll sit down with the other group, and it's up to me to figure out, to find what they have in common that they can agree on, and then let's try to move there. So it's one where I have to assess the situation first to figure that out.
Well, so on a positive note, I have to tell you, because of the accountable care organization that we had, so that did change our relationship with the insurances, where we have a better relationship on the clinical side. But these issues are on the revenue cycle management side. So, like, on one hand, I meet with them on a monthly basis. Like with Highmark, we have two monthly meetings. It's been almost 6 years now. So, but that's on the clinical issues, like how we can close the quality gaps, how we can make the insurance coverage expenses less. We can decrease the expenses. On those, we are working as a partner. Like, there's no difference between the two groups. Mm-hmm. On the other side, this old revenue cycle management side, it's kind of like they're disconnected. So, like, I have one great meeting, and then we are like, oh, we work with them as a partner. And then my next meeting with the same insurance is like, well, you haven't paid 10 claims because of the authorization or because of this or that. So there's still some issues maybe on the other side, but we have been much better. I have to kind of say that, because we work with these individuals, and I think if we can maybe make the regulations, and I'm kind of surprised in a way. So, one of the reasons I'm surprised is I always tell other people that healthcare is one of the heavily regulated industry in the United States, right? So because of that, you would think that everything would go by the book, but it doesn't happen. So it
Yes.
doesn't happen. So now, well, you have another interesting bill that you've been working on it for a long time, and I didn't know that, of course, until last week, which I need to do a little bit more. I need to be more efficient with my homework, I guess. So assisted suicide. So this is not legal in Delaware yet, right?
That's correct. And so I want to mention two things off the start. First thing is I started this the same time we did the prior authorization. 2015 is when I first introduced this bill. And the second thing is that it's not, we do not call it assisted suicide. It's not considered assisted suicide. It's medical aid in dying. So when somebody is already in the dying process, it defines a path where they can work with their healthcare professional to have assistance during that time. So whether it be a doctor, an MD, or an advanced practice RN, they work with them, make sure, as you say, it's highly regulated. They follow all the steps, but if they pass through all the steps, then they can have a prescription made out that they can collect, that they can self-ingest to identify their last day. So this is someone who has terminal cancer that's expected 3 months to live, and they can go through the process, and maybe after a month, they get through it, and then they can choose what their last day is. And that's based on knowing themselves and working with their healthcare professional.
So how did you decide why did you pick that bill? And I'm just like,
yeah, sure.
Just curious, like you could do a lot of different ones, right? And this is an interesting one. And I know some states, they already have this legalized. So were there any like personal reasons?
So I'll say, I'll give two quick reasons. One is probably in 2014, I was out playing tennis in Newark, and in the court next to me were 4 people playing tennis, and we happened to finish games at the same time. So we were talking in between, switching over, and one of the ladies in the court next to me handed me a magazine from the organization, one of the organizations that promotes this, called Compassion and Choices, and she happens at the time to have been the mother. She is the mother of who was at that point the governor of the state of Delaware. So she's a constituent. She's the mother of the governor. I'm going to listen. So yeah. And then I looked through the magazine, and I mean I knew some of the issue, but not too much. And everything I read said we should be empowering our residents who are dying to have a say in that path. And if they want to go through, give me every medicine, or I'm going to suffer however the universe wants me to suffer, that's fine. But if they say, I'd like to have the help of my doctor, I'm here. I want to make sure there's not a wall that government doesn't get between the dying person and their doctor.
So it's a touchy subject. So I actually don't know how I feel about it. So now I'm glad that you're a tennis player. So Sean and I, we were just checking your website. You didn't list any of the hobbies. So I'm a tennis player as well. So I try at least a couple times a week. So where do you play?
So in the winter, I played Elkton indoor tennis.
Okay.
Off of Route 40. And in the summer and spring and fall, I'll play in any of the area outdoor courts. I'm thrifty at all the free outdoor courts in the greater Newark area.
So I'm at DuPont for about 12 months, I guess. So well, maybe we should play one of these days. And I have a couple of good tennis players in my office. They're actually like college level. So
you got to pair your best player with me. That's the only chance I'll have.
Well, that's how it is. So we have 2 of them. So you can take one and I'll take one. So, well, of course they're like really good. So if I can get a couple of games from them, I'm doing good.
I understand.
So now, from the personal side, I'm trying to kind of understand this, and maybe there's some information that perhaps you can provide. So at what point person can make this decision or should make that decision? Like I'm 49 years old. I don't have any serious health issues. Do I make that decision now? Because when the thing is, if let's say if that's how I want to do it, let's say if God forbid if something really bad happens, in many cases, the mental status of the person is not so great. And a decision that they are making at that time is not a good decision.
Right.
So, at what point in this bill that you have, how is it suggesting that at what point they would make that decision, or how late can they make that decision?
Sure. And you raise in very, very good points. It is unlike you can have an advance directive, and you can do that at 49 and say, should I be come into a vegetative state? I want to have everything, or I want to have liquids, or I want to have liquids and foods. I want to have pain meds, or I want the plug pulled. Okay, and you can set that when you're healthy, and that is your legal direction for what you want. Should that happen. We have a Delaware medical order of scope of treatment, DMOST, and that is only valid once you are already have a terminal diagnosis, and it's a medical order, not a legal order. So a legal order is sort of a suggestion. A medical order says, if you're part of the medical community, you sure as heck better follow that. So that's one where you already have a terminal diagnosis. And that's available to you. This is the same way. This, you must wait until you have a terminal diagnosis for it to be available to you. That's one of the many, many safeguards. And I say that because one of the concerns people often have is, well, what if I get advanced dementia? I know that once I'm terminal, I don't want to be, wait until my body completely shuts down and have the pain over the last few weeks of that. But if I have dementia, I'm not going to be able to tell you that. And that's one where we say, we would love to help you, but we cannot. That's a safeguard that is sacrosanct. We do not cross that. The individual has to have the terminal diagnosis and must be a mentally capable adult. You cannot have your power of attorney make this decision for you. The patient themselves, the dying person themselves, has to drive every step of the process.
Well, I think the advanced directives is important, and that's one of our quality metrics with most insurances. Now, many people really don't understand what advanced directives is. Like, if you go to any of the offices, they may just say that, well, do you have a living will or not? So then that's not your advanced directives. Advanced directive is, as you were earlier explaining, how you want to be treated, what process you want to go through when you are not able to make that decision in the future. Yes. Now, that's a little bit different than the, I'm going to use the same word that you use, same term that you use, medical aid, right?
Medical aid in dying, MAID, you can say.
Medical aid dying. So, although I kind of like the assisted suicide better. So.
Well, the reason we don't use that is if I'm committing suicide, I'm stopping a life that is still going on. Okay. Medical aid in dying is it leads with admitting this person's dying. So you're not ending a life that's going on. You're choosing which day the person actually the person is choosing which day they die on. So it's very different. It's completely different from suicide. Oh, you mentioned mental state. Pretty much by definition, if someone is committing suicide, they have a mental depression, mental illness going on, at least episodic at that point. With one of the safeguards we have is we make sure that the medical professionals who are taking part in this process, including all the safeguards, they're making sure if there's any evidence of a mental illness, including a clinical depression, that makes them ineligible for this. And they may have to refer them out to a psychiatrist to verify that or not. So we make sure that, frankly, if I get a terminal diagnosis, I'm not going to be happy. I get that. And I might be depressed, and I get that. But whether I'm clinically depressed and if that's clouding my judgment, that's something for a medical professional to assess. And if they see any signs of that and they confirm it, then I would be ineligible for this, even with being an adult and having a terminal diagnosis. So that's one of the many safeguards we have.
Yeah, I think the key is to make that decision before it becomes a reality. So that now one of my really close friends' grandmother was in the hospital for 32 days. And 30 of those, she pretty much, she was already gone. She was, I think the tube feed and all that's like, she was gone. But if it was her decision that time, she probably didn't want to go through that. And I always say, if I become that, then I don't want to be on the plug and just pull the plug. So I say that it's a little bit easier now, but then when it becomes a reality, I don't know what happens. So, and then there are always some miracles, but I think, I'm probably like 60-40, like 60 supporting, 40 not supporting, but perhaps need a little bit more education on this. Now, how many states is already was able to legalize this?
It's somewhere around 11 or 12. New Jersey is the nearest one. Maryland is close to passing it, but they haven't done it yet. And again, we've been working on our 8th year now. But we're getting it done. We're pretty close to the finish line.
Just from the healthcare provider side, what you may need from us that maybe we can provide? Not necessarily, I don't know if I want to support this or not, but let's say if we can, and if there is something that you may need from us, from the providers, is that something that we can provide for you?
So I think there's a few things. First thing is, again, this bill is just complete with safeguards. And one is there's going to be a lot of medical professionals who want to have no part of this. Okay. And there's going to be organizations like, for instance, St. Francis Hospital that says, you sure as heck can't do this on our property because we, with the Catholic Church behind us, don't believe in this. So we say, you don't want it, you don't have to do it. No one can be compelled to do it from a patient perspective or provider perspective. But there are frankly, we have the Medical Society of Delaware, which is made up of physicians, and they've chosen to be neutral in this and leave it to their members to decide, do they wish to be willing to participate on this or not? And that's exactly as it should be. So one of the things we want to do, and the national organizations that work on this, that work with the states where it's in place, is you want to help providers know, how do you work with the patients through the process and say, okay, yes, you're eligible. You know what? Because you're asking those kind of questions, we're thinking we don't want to rush this. You may need some extra time. So let's help you with that. Maybe we want to bring in a family member to help you with that, or encourage you to go home, speak with your family members before you come back. And we've got multiple steps you need to go through as the patient to go through this. So there's ways to train the professionals so that they're prepared for this very difficult new option at the end of life.
It's kind of like similar to how hospice care started, and it's now more, everyone knows about it, but 15 years ago, that was not the case.
Oh, absolutely. Interesting.
So
Oregon, I like to use this phrase, Oregon has had medical aid in dying since last century. In other words, say it was done in the late 90s. So in the late 90s, Oregon did it. So they've got, I think they've got 25 years of data on this. They find that at least 85% of those who choose the medical aid in dying path are also enrolled in hospice. So there's a misconception this is an either or. By no means is this an either or. You still want somebody to work on that palliative care, to work on the pain. You need that hospice. Hospice also helps not only you, but your family members in dealing with the transition that's coming. So these are not either or. These are very much complementary for the dying individuals who wish to have this path available to them.
Understand. Well, Representative Baumbach, thank you so much. We took a lot of time from you, and thank you for coming to the show, and we'll be following up with you. And I really would like to sit down and meet with you with a couple of these issues.
I'm looking forward to it.
All right, we'll reach out to you. Thank you so much again.
Thank you. Take care.
Bye-bye. Bye. All right, well, let's get Sean in. So I know we are kind of running late. Yes. Well, I know it looks like we are in two different rooms, but we are in the same room. So many people don't.
The lights are on this side.
Yeah. So it's like last week with Dr. now. The background.
Yeah.
So okay. Now this was a good conversation.
Agreed. That's very informative.
Well, I was just thinking, like, why did I not know about him?
Mm-hmm. Well, I mean, it's as we peel back some of these layers, that's when we find out some of the people who are behind, obviously, different bills and kind of what their involvement is, and the fact that he was saying he's been involved, 7-8 years now. Mm-hmm. You just see the type of work that people are putting in, but obviously, our job here to ask the questions that are needed, dig deeper, and kind of get to solutions. So maybe any of these barriers that we're seeing, kind of roadblocks that are preventing us from getting from A to B. That's kind of what we're here to do. to help get that progress. Yeah.
Interesting. So, it's also like interesting. It's fine. Like I didn't know, but then they also didn't reach out. So I always tell these state officials, like number of patients we go through. I mean, you remember the appointment numbers? It's close to 500,000 a year, every year. So that's average 4 appointments, 100,000. Average 3 appointments, more than that. That many people are going through the system, and that's as we expect from them. Maybe this is again one of the reasons that we want to be more visible is because of this.
Yeah,
so,
the impact, of course.
So now I know we have other discussions that we have a little bit time issue here. So I'm going to let the because we had some technical issues in the beginning. The laptop is a little bit far from me. So should we cover the
Well, we have a couple things.
Yeah, let's go ahead.
So we have some is more focused, again, U.S. economy. We were talking about that in our previous weeks about the U.S. dollar and what that means for our economy as a whole, both obviously domestically, but then on the global scale, and kind of how the U.S. power shift for the beginning of what we may obviously determine a power shift later on when you see these other countries like China making these deals. And we also just have our global events tracking kind of some other protests, global conflict tracker, and other unrest that we're seeing with other countries. I know if you're following the news, you'll see like France, Israel having these protests.
Well, let's go back to the U.S. one, because we do have a really important historical week, and then probably a couple more weeks coming up with President Trump. Yeah. So what happened with him?
Yeah, so I'm pretty sure it was a couple of years ago when it first started, but with the indictment and the fact that he was arrested, and then the case of him denying, I believe it was 36 charges that he pled not guilty to, and kind of this entire court case is going to unfold from this. But also, just to backtrack before we dive into it, just a reminder of keep in mind what else is happening and what the news is covering. Obviously, Trump with this, it's a important aspect of the news. You'll see it on all the headlines, but also think about the fact that, Finland joined NATO. We didn't really see too much on that. We also have the fact of these currencies, the Russian ruble going down to its lowest value since 2022. So there's other major things happening globally that aren't seeing the same screen time necessarily. I was also just thinking of our example we had, months ago when all the news cared about was Johnny Depp and that trial. And meanwhile, there's other with the Clinton and Ghislaine Maxwell happening at that same time. And you see what the news chose to just keep feeding into. So I'm not saying that the Trump issue isn't important, but also just to remind everyone, keep in mind what else is happening at the same time. And I guess up to them, viewer discretion on what they feel is more impactful on the global shifts or whether he's charged with some of these things. So.
Absolutely. I guess the part of the issue is there a political motivation, right? So if there's a political motivation, then you have to be extremely careful. What used to make the United States great is these issues would happen in the less developed countries, wouldn't happen here. So you may have like a politically motivated person or people, but then system here is so strong that you wouldn't be able to go through the system even if you want to do stuff. And then that actually first time is happening. That's why this is historical in a way that someone like, if you take what you feel about Trump, how you feel about Trump, you like him or not, he was our former president. So he was actually, until, and probably now, he's still being protected by the Secret Service, right? So isn't that kind of like
and their immediate families are still followed?
Oxymoron in a way that so you are protecting the person now you're arresting. They have people in the jail with him, and then why? I mean, if anyone needs to go to jail for anything that you did, they did. One thing that I was reading something that was saying that were they trying to set him up so then Biden would pardon him, like you know, then that makes Biden the bigger person.
One
is it going to
positive.
get to that point? One positive, two maybe, not more than four. So
Yeah.
but that's what it is. And when we have all these issues are happening outside of the world, that's affecting our economy. So it is affecting what we have today. When we picked up on the global issues, you may, well, because you are always with me in these, the way that we are processing and preparing, the global currency was not on the headline when we started preparing for that, because it was coming. I could see that was coming, and why we were actually, one of the reasons that I was actually more interested in finding out a little bit more is because how can we make really bad financial decisions? And then I was like, because we own the money, right? So, and then when you put the tension on the other side and how that's going to go to the next level and what those other countries, which they are doing it already. We discussed that last week. So I guess next week we can do a little bit more. What do we have next week? Do we have a guest?
I don't believe so. I think it's the following week when we have
the clinical presentation.
Yes, we have.
So we should have a little bit more time. And State Representative Baumbach was very generous with his time, because normally we had him only for 20 minutes and he stayed for longer, which was great. And that's part of the reality with these, when we have guests, we never know how long it's going to be. So we can actually cover some of those next week. I'm really worried about what may be coming in the near future for this country, and I am worried. So I can't help but worried. So I'm hoping that we won't, people will come to their senses and will stop acting crazy in a way. So politically motivated decisions or behaviors cannot be rewarded in this country. It shouldn't be, regardless of who they are. Bill Clinton gets a blowjob, fine. Trump does whatever he did, pay the stripper, fine. Biden's son is doing a lot of dirty stuff, no one is in jail. So this can get really ugly. 50% of this country is on the other side, 50% is on the on one side and 50% on the other side. So that's a war in some cases when you put too much attention and you divide these people to a point where they hate each other, which this will make it really really bad. So hopefully we won't get to that point. We have our Bariatric Friday with Dr. Erkan, and maybe we can also have Dr. Erkan covering the book. He's doing really well with the sales of the book. I know we are going to actually reach out to some people. We got some extra copies. So hopefully more people can read, and we can discuss more about how he's doing with the book, and hopefully other people also would be done reading it, including yourself, right?
Yeah.
Did you start yet?
I didn't start yet.
Okay. So 2 weeks. So we should actually have some maybe group discussion with maybe bring a couple of other
That could
people.
be our learning and literature. I know we used to have that, our featured book. So we could bring that back for sure.
And I'm thinking that maybe a couple of our people from our office, they can actually, we can have a group session. We did it for COVID, how COVID affected people.
I saw, I remember. Yeah.
I think we can do something like that so then everyone can tell us their take on the book.
Good idea.
Well, thank you for being with us and watching us. We'll be back with the Bariatric Friday in a couple of minutes, and we'll be back with this event next week. And until then, stay safe and have a great weekend.
Thank you.
And also, happy Easter. So we forgot about that.
Easter Sunday.
So today is Good Friday. Well, every Friday is a Bariatric Friday, but today is a Good Friday, right? So, happy Easter for anyone who's celebrating.